everyone. My name is Amy Estry. It's my pleasure today to welcome you to the Maternal Health Learning and Innovation Center's webinar, State and Local Implementations of Plans of Safe Care. And on behalf of the MHLIC, thank you so much for joining us today. Next slide. Before we begin, we want to acknowledge that the MHLIC is supported by the Health Resources and Services Administration of the U.S. Department of Health and Human Services, and that today's content is that of the speakers and should not be construed as official policy of HRSA, HHS, or the U.S. government. We would like to note that all participants are muted upon entry, and that questions can be submitted via the chat Q&A. And although there's a lot of information to cover, we will try to have a few minutes for Q&A at the end. We'll also send out an evaluation survey link to all attendees, and we encourage you to complete that at the conclusion of the webinar. If there are any remaining questions that are unanswered, please contact MHLIC via the website at maternalhealthlearning.org. We would also like to acknowledge the partners of the MHLIC. MHLIC is comprised of partners dedicated to collaborative leadership in maternal health. Next. Today's learning objectives are for participants to be able to learn different state and local approaches to implementing plans of safe care and connecting families to appropriate services, discuss interdisciplinary approaches to optimize plan of safe care implementation, and highlight tools for implementing plans of safe care. Next. I will now very briefly welcome today's speakers. And in the interest of time, I will not be reading their full bios, but please visit the landing page for this webinar under the events page at maternalhealthlearning.org to learn more about each speaker. From the National Center on Substance Abuse and Child Welfare at Children and Family Futures, we welcome Jill Gresham, the Senior Manager of the In-Depth Technical Assistance Program there. From Washington State, we welcome Alissa Copeland, the Early Childhood Program Manager for the Washington State Department of Children, Youth, and Families, or DCYF, and Sarah Holdener, the Help Me Grow Lead at the Washington State DCYF. From San Francisco, we welcome Dr. Heather Briscoe, co-founder of the Plans of Safe Care Community Collaborative in San Francisco, and Marcy Spaulding, a registered nurse and public health nurse with the Family and Children's Services Nursing Unit, which is part of the Maternal, Child, and Adolescent Health Division of the San Francisco Department of Public Health and the San Francisco Human Services Agency. And from Houston, we welcome Dr. Beth Van Horne, an associate professor of pediatrics at Baylor College of Medicine and the director of research for the Division of Public Health Pediatrics at Texas Children's Hospital. Thank you all for agreeing to share with us today. And I will now turn things over to our first speaker, Jill Gresham.
Thanks so much, everyone. So today I wanted to give you a really brief overview of plans of safe care. For those of you who were here for the part one of this series, this will be a little bit repetitive, but we wanted to make sure everybody has a good foundation going in terms of plans of safe care. So on the next slide, just a quick acknowledgement that we here at the National Center are funded by the Children's Bureau and the Administration of Children's Families and by SAMHSA, which is the Substance Abuse and Mental Health Services Administration. So just a really quick why we're here today and what's driving some of this work around addressing infants born affected by substance abuse. What you're looking at here is data. This is national data that's sent in from state child welfare systems, and it's looking at kids who have gone into out-of-home care for any reason. And what we're seeing nationally and in every state is that kids under 1 year old in infancy are going into out-of-home care at much higher rates than children of all other ages. And when we see that happening, we know that one of the primary reasons for this is due to parental substance abuse. So we want to talk a little bit about the tool of the plan of safe care to address this. So on the next slide, specifically, we're looking at legislation, which is the Child Abuse and Prevention and Treatment Act, or CAPTA. So CAPTA, you'll see on the next slide, is a piece of legislation that's been with us since 1974. We're talking about a small piece of CAPTA that addresses infants born exposed to substances, and that appears first in 2003. There's an update in 2010, and then there's some more significant changes in 2016. So on the next slide, you'll see some of the language from CAPTA, but specifically this piece of legislation mandates that infants who are born affected by substance abuse, by withdrawal, or by fetal alcohol spectrum disorder need to have a plan of safe care, and that plan of safe care needs to address both the needs of the infant and the primary caregiver. So on the next slide, you'll see that the language in CAPTA is a little bit maybe vague, but it allows for some state interpretation. And so no state is implementing CAPTA and plans of safe care the same really as their neighbors, right, across the country. So as healthcare providers working in states, there's some issues, so pieces that you might have to do a little bit of research on to understand what plans of safe care look like in your state. So the first piece is to understand who needs a plan of safe care in your state. So that language of affected by substance abuse can be a little bit tricky and nuanced. So a lot of states have dug into that and defined it, right? So it might be an infant who is born exposed to marijuana or one born exposed to methadone might be someone who needs a plan of safe care in your state. Some states have put in two different pathways to support infants and get them plans of safe care. So in some states, if there's child abuse and neglect concerns, those infants go to child welfare. But if there's not, then oftentimes there's a secondary pathway where those infants go with their families to a community provider who does the plan of safe care. And so not all states are doing that, but some are. So it's good to do some digging to figure out if your state is one of those notification pathway states. If you do have a notification pathway, you need to understand who is overseeing that plan of safe care. And so we'll hear from 3 different states today with 3 different organizations and community providers who are doing those plans of safe care. And then finally, what is the actual template for the plan of safe care? So the legislation doesn't come with a specific template. So you might find a single state template, you might find different templates at the county level or even at the community level. You can find some of this information out by connecting with your state child welfare agency. Sometimes you'll see this also with your state Department of Health. Oftentimes we're seeing state departments starting to put up websites that capture a lot of this information. If you're unfamiliar with the plan of safe care, it is sort of it's a collaborative tool. It's not the same as a safety plan, which I'm sure you're familiar with, because it goes beyond just the safety needs. It's not the same as a substance use disorder treatment plan because it goes beyond recovery needs, and it's not the same as a hospital discharge plan because it goes beyond health needs. Instead, it's sort of a conglomeration of all of these pieces. And again, it's that family focus across both infants and their caregiver. If this is new information for you, I highly encourage you to find our website on the next slide. We are, again, the National Center on Substance Abuse and Child Welfare. This QR code takes you to a catalog that's just full of many of the tools that we provide. You can, again, find these on our website. So there's tools like on the next slide, you'll see we have a learning modules on how to implement plans of safe care, really from that preparation stage all the way through implementation and then oversight. We also, on the next slide, have another series that looks at how have states implemented plans of safe care, how do they look different, and what are some of the challenges and barriers that they've dealt with. We take all of this on the next slide, you'll see, and take a look at implementation and challenges related to an equity lens of practice. And then finally, on the next slide, you'll see we have a lot of different resources around understanding risk and safety. So all of this is available to you on our website. Again, we're also a resource center. So if you had questions, I always say, don't reinvent the wheel. We probably have an example. So you can reach out directly to me or through the National Center. There's a general mailbox on our website. And if you're looking for an example of a plan of safe care or a verbal screening tool, or want to just talk about what challenges folks have had implementing specific models, we're happy to talk with you. So with that, I'm going to turn it over to our state presenters who are going to get into the nuance of what it looks like with different implementation models. And we're going to start with Washington State and Alissa.
Thanks so much, Jill. I'm Alissa Copeland, the Early Learning Program Manager with DCYF in Washington, and I'll pause and let my colleague Sarah introduce herself.
Hi there, I'm Sarah Holdener. I also work at the Department of Children, Youth, and Families in Washington State, overseeing the Help Me Grow system.
Thanks, Sarah. Next slide, please. So we're going to talk about initial implementation and what we've learned here in Washington. Next slide. As Jill mentioned, we did a lot of work prior to implementation, and it required a significant degree of cross-system collaboration, and we received a lot of support from Jill during that time as well. But the main agencies and organizations that are supporting this work and have from the very beginning are our agency, the Department of Children, Youth, and Families, the Washington Department of Health, the Washington State Healthcare Authority, and next slide, please. Oh, I'm sorry. There's two more that I'll mention. Looks like they might have gotten cut off in that other slide, but it's our Washington State Hospital Association and Within Reach, which is a community-based organization that serves as our statewide Help Me Grow affiliate. So with that collaboration, we developed a system in Washington where we have partnered very strongly with our birthing hospitals, and they participate in they engage by using an online referral portal where they identify an infant as being substance exposed in this portal, and they determine whether or not a notification or a report is needed. And Jill mentioned the notification and report dual pathway. That is what we built in Washington. If a report is needed via the questions that they respond to in this algorithm in the online referral portal, they're directed to call our DCYF child welfare intake. If a notification is required, then they're directed to a Help Me Grow referral for the family to receive a plan of safe care in the community. Next slide. We did a lot of work before we launched this online referral portal to determine when reports are required to DCYF intake. And so it's typical situations where you might see safety concerns, positive toxicology for confirmatory testing for an illegal substance or non-prescribed substances, when newborns are demonstrating signs of withdrawal as a result of use of illegal, non-prescribed or misused prescribed medication or undetermined substance exposure, and when there's evidence of ongoing substance use by the birthing parent that creates safety concerns for the infant. So those are the types of situations which the algorithm will direct birthing hospital providers to call DCYF intake. And then the types of situation, next slide please, that would require just a notification. Oh, I'm sorry, one back. And a referral to our community-based pathway would be the kind of situations where a birthing parent is taking methadone or buprenorphine as prescribed, any other opioids being taken as prescribed, healthcare provider verifies that the birthing parent is taking any other medication or combination of medications that have abuse potential as prescribed, and prenatal exposure to marijuana only. And then of course, with no additional safety concerns impacting the family or situations that might lead to imminent risk of harm. Next slide, please.
Great.
All right, I'm going to hand it over to Sarah, who's going to talk about Help Me Grow.
Great, thanks, Alissa. So as Alissa outlined, Washington is developing or has developed this community-based pathway for families receiving Plan of Safe Care notifications. And Washington State selected Help Me Grow Washington as the approach to connect the families in this pathway to resources and community supports. For those of you who are unfamiliar with Help Me Grow, it is a systems approach rooted in community to connect young children and their families to the resources they need. So I like to think about it as this network of people, partnerships, processes, and some technology all coordinating together to best support providers and families and navigating the early childhood system, which can be complex. Help Me Grow is a national fidelity-based model. And last I checked, about 29-30 states are implementing Help Me Grow systems. And in Washington, the state affiliate is Within Reach, who has been a big part of this work. They're a long-standing nonprofit organization with deep expertise in building pathways for families. Next slide. So as Alissa referenced, we did a lot of stakeholdering work before this was launched for a couple of years. And one thing that we heard loud and clear is that families receiving a plan of safe care through either pathway, right? Whether they're going through child welfare to receive the plan of safe care or through the community-based pathway, that those families should have access to an array of wraparound services and resources, such as early intervention, home visiting, mental and behavioral health resources, parenting supports, concrete supports, such as like newborn supplies. And so when you imagine all of these together, you can see how these elements of a plan of safe care can really strengthen protective factors, promote healthy development, and just broadly support a parent or caregiver's ability to meet the infant's needs. And then if you compare what is needed or the elements of a plan of safe care, if you compare that to what Help Me Grow Washington specializes in, which is on this screen, you can see how many of those plan of safe care supports align with the scope of services and resources that Help Me Grow specializes in, which is what led to Washington State choosing Help Me Grow as the community-based partner in this work. So when you're thinking about the work in your state, it's important to think of like, what are those elements of a plan of safe care and who in your state or in your community are best set up to provide those to families. Okay, back to you, Alissa.
Thanks, Sarah. Next slide, please. So we wanted to share with everybody a little bit more about our collaborative effort in Washington, what we've learned, and our next steps, because we are still right in the middle of statewide implementation. Next slide. So from 2021 to 2022, we had the following accomplishments. We really strengthen our cross-sector stakeholder team that's driving the work. I mentioned the state level agencies and within reach, the collaboration across systems. We were recommended and connected in other initiatives as part of the Washington Opioid and Overdose Response Plan and our Washington Maternal Mortality Review Report. We participated in a lot of webinars like this one, sharing our process and what we've learned with other states across the country. And our Plan of Safe Care project within DCYF is the largest project that's part of our Washington CAPTA state plan and a primary focus of our citizen review panels, which are a component of our CAPTA grant as well. We launched our first 2 pilot sites in June of 2021 in 2 very different areas, both demographically and geographically within our state. And then by December of 2021, we launched the online referral portal, which effectively made our community-based pathway available statewide for any birthing hospital that was to begin using that referral portal. In 2023, we're going to continue our engagement strategies with hospitals that we do through this cross-sector partnership. A lot of us are carrying the load in terms of communicating with and engaging with hospitals and training them how to use the portal. There's a connection to mandatory reporting training that we like to fit in there as well. So it's definitely a collaborative effort. And then finally, we built some infrastructure around our 2 pathways. We developed our online referral portal. Help Me Grow at Within Reach established a mental and behavioral health team that is the team providing the community-based pathway. They've gathered probably even more than 1,100 plus resources at this point across all 39 counties. And we continue to explore statewide and community-based referral partnerships as we launch this in any given community. Next slide. So we've done a lot of work, as I mentioned, with hospitals and with communities. Early on, we worked together to define that CAPTA language that Jill referenced earlier. We have identified aligned initiatives with our partners. For example, our Washington State Hospital Association has a Safe Deliveries Roadmap initiative that is very much aligned with this work. And so we partner with communication and training opportunities in that regard. And we're doing a lot of work to meet communities where they are. We found that some communities already have really robust collaborations that are working with this population and even have some systems set up within their community that look very similar to what the community-based pathway looks like for Plan of Safe Care. So we are not wanting to change that and only support that in each community by perhaps the use of our online referral portal, providing some infrastructure and access to maybe other state level services that they weren't accessing in the work that's already doing. Next slide. So we've conducted hospital listening sessions over the last 12 to 18 months in various different venues. And right now our partner at Within Reach is doing a lot of this work to determine the best way to support hospital engagement and sustainability in using our online referral portal and understanding the plan of safe care. And what we've learned is that we need to provide a little bit more clarity around identifying safety concerns, that policies around screening and testing for substances, as well as reporting to CPS, vary across our state and may not be consistent or aligned with the Plan of Safe Care body of work. And we've identified some concerns around equitable access as a result of inconsistency across hospital reporting and policy as well. And then finally, a need to improve frequently asked questions document and provide a higher degree of technical assistance. I think both in terms of understanding the Plan of Safe Care and this body of work and how it works in Washington, as well as true technical assistance with utilizing the online referral portal. Next slide, please. So all along, we are actively providing training and support to hospitals and other providers. One of the things that we are really focusing on is that hospitals are obtaining consent for a referral to Help Me Grow, regardless of what pathway they think the algorithm might tell them to send the family to. And we want hospitals and providers to be really transparent about the fact they might need to call child welfare intake and explaining the Plan of Safe Care to families so that they understand there are two pathways, and a family could potentially start on our child welfare pathway and then perhaps be referred over to the community-based pathway, depending on the intervention need for child welfare services. So we want hospitals to be well-versed in the process in Washington so they can explain it to families at that time of the birthing event. Next slide, please. So also very important to us in this body of work is that we're addressing racial equity. We've certainly found that policies and practices in hospitals can vary, like I mentioned, around testing of newborns. We found early on some disproportionate outcomes in terms of certain areas of our states referring African-American families with marijuana exposure only to CPS intake when other areas of the states were not, and at a disproportionate rate. Our Plan of Safe Care online referral portal collects data on hospital reporting practices and screening and testing so that we have that information available to us. And we also collect data around race and ethnicity of the referrer. And this will help us in the future analyze and tell some stories around racial equity and also identify opportunities for anti-bias and mandatory reporting training, as well as potentially support policy that standardizes screening, testing, and referral practices just through our collaborative effort with other agencies. Next slide. So in 2023, we've got some implementation goals. We have updated our child welfare policy and practice around intake screening so that it is more in alignment with our two pathways in Washington. We have goals to collect data and report out to the public on implementation, and if once we've collected enough data around instances of prenatal substance exposure, we plan to share that as well. We're conducting a targeted case review on child welfare cases that require a plan of safe care, and we're identifying ways to send our screened out child welfare intakes to Help Me Grow so that families have the opportunity to participate in the community-based plan of safe care pathway if they are not screened in for child welfare intervention. And then finally, within child welfare, we're utilizing the plan of safe care as a family-centered case planning tool and in just strengthening its use as a practice tool for families with substance-exposed newborns. Next slide, please. Our goals around hospital engagement is to champion our high users. We have several hospitals who have jumped onto using our portal, and we really want to lift them up and support them in their ongoing use and learn from them so that that will help us support other hospitals to begin using our online referral portal. We want to strengthen collaboration in the child welfare field with birthing hospitals when cases screen in for child welfare intervention, and they have to engage in collaborative discharge planning in a very short period of time. we're going to continue to tie our hospital training to mandatory reporting, and we've identified this population of mandatory reporters as a population that gets some specialized training, including our plan of safe care pathway and online referral portal. And we're going to support hospitals to implement aligned efforts and policies, especially through our partnership with Washington State Hospital Association. Next slide. With our online referral portal, we're going to continue to gather user experience data. We are looking at ways to develop a risk assessment to strengthen the safety assessment algorithm and to support the hospital's need for further clarification and understanding around what exactly are safety concerns. And we want to look at ways that we could build out the functionality of our online referral portal in terms of connecting it to other referral pathways for this same population. All right, thanks so much.
Okay, good morning. My name is Marcy Spaulding, or good afternoon, as the case may be. I'm a public health nurse with Family and Children's Services in San Francisco and Department of Public Health. And I'm here with Dr. Heather Briscoe. I'll let her introduce herself.
Hi, I'm Dr. Briscoe. I am a pediatrician at the County Hospital in San Francisco, and I'll leave it at that.
All right, so we're looking forward to sharing with you about our plan of safe care work in San Francisco. So I want to start with some brief context about plan of safe care implementation guidance given by the state of California, since every state is different in its approach. The state released an all-county letter in 2017, which notifies of the requirement to notify CPS of all substance-exposed newborns. But in their definition, they include an element of risk. So essentially, they made no change to current practice and how referrals or notifications are made to CPS, but did indicate that child welfare departments must ensure children and caregivers are referred to appropriate services, and they must document this. They leave it to the county to figure out who develops the plan of safe care and who oversees it to ensure the needs of the infant and the affected caregiver are met. And they do allow a child welfare case plan or safety plan to act as a plan of safe care. In San Francisco, providers and community partners saw this as an opportunity to address the needs of this vulnerable population, and we were also not restricted in how to do this. Next slide. So the state in 2020 released another all-county letter, which makes some clarifications. The new guidance recognizes that a plan of safe care may come from outside of child welfare, so a provider-initiated plan of safe care, and that this plan can be used to inform the child welfare safety plan or case plan. It reiterated that California's definition of a reason for notification requires an element of risk, not only concern for prenatal substance exposure, so this is different from other jurisdictions. It did address medication-assisted treatment specifically, stating that in the absence of other safety concerns and or risks, anticipated withdrawal symptoms resulting from MAT as part of a stable recovery journey would not necessitate a CPS investigation. And it stated the importance of coordination and collaboration within local healthcare communities. There's no guidance given on substance-exposed newborns who do not meet a threshold of risk for CPS, so this is a gap we're working to fill. So why were we interested in this work? Racial disparities were a primary concern. California is the state with the greatest degree of disparity for Black children in foster care. The numbers here reflect the degree of disparity for the state of California, which is striking, and the data in the city and county of San Francisco is substantially worse, with Black children being 28 times as likely to be in care relative to white children as of last year. It was this stark reality that motivated us to form a collaborative and better support San Francisco families. Next slide. So what was our response? The first and most important thing we did was meet and learn from various stakeholders in the space of substance impacted dyads, which you can see many of them listed here. Relationship building is super important. It's building trust among providers while advocating for families and understanding why we do what we do, understanding child welfare timelines and barriers, and then working together to improve and remembering that we're all working towards the same goal, which is the safety and well-being for children and families. Next slide. So in 2019, we formed a collaborative and brought together perinatal hospital staff, child welfare staff and leadership, Department of Public Health, community-based organizations, treatment providers for monthly meetings to start. We did a collaborative values index with support from Jill Gresham and Children and Family Futures to get a sense of where we're starting from with regard to the values of our collaborative partners around substance use disorders and child welfare. We received 160 responses from primarily medical providers, maternal, child, adolescent health staff, including public health nurses and child welfare workers. There was agreement around most of the items, demonstrating a shared understanding of many of the challenges our families face, an agreement that we need to partner with families and with each other to achieve better outcomes. We also partnered with a human-centered design group called the Better Lab to look at flow of patient experience through various perinatal care services and systems. We learned that we ask hundreds of questions, often asking patients to retell their stories repeatedly, which is not trauma-informed care. Patients rarely see the same person twice, and the care team members never seem to know what one another is doing or has done. So this is something that needed to be addressed. Next slide. So this timeline just briefly shows a summary of our plan of safe care work that began with the information gathering and relationship building just described. Then in collaboration with stakeholders, we created our plan of safe care template, which was tested at our safety net public hospital, Zuckerberg San Francisco General Hospital. But as we will discuss, the plan of safe care work has become really much more than a document. We'll highlight the dyad care coordination timeout, which is one of the key initiatives that has come out of this work, as well as ongoing collaborative efforts. Dr. Briscoe?
Great, awesome. So I think next slide. As with Washington and many other places, our plan of safe care is really focused on identifying what are the strengths of the family, what challenges are they facing, and how can we align resources around the family to really optimize their strengthen their protective factors and their likelihood of success. Next slide. One of the things we really learned, though, is that from our pilot is that the plan of safe care has turned out to be so much more than this document. It's really much more about the framework of organizing around a family, ideally before the birth event, so that you can really mitigate the risks that might trigger a call to child welfare. And so it turns out in part because of the technology issues with documentation, but it really is about just organizing and aligning these resources, which are heavily rooted in community for us. Next slide. And simultaneous to this effort with the collaborative, there were some key things that happened, and the first of which was the formation of a innovation and care called Team Lily, which really was centering these patients by making care really accessible and rooted in harm reduction, so that we could begin to see some of these families who were wrestling with substance use disorder. Next slide. And then in the hospital, much like was called out by Washington, we really looked at when we are using urine toxicology assays, as we know that they are more often applied to people in public hospitals or to Black identifying parents. And we really narrowed those indications for using that assay. And then the other thing that came out of this perinatal and pediatric equity task force was we called it a family safety timeout. And I will speak more to that on the next slide. Go up, please, the next slide. We renamed it the dyad care coordination timeout, just because families felt like it was a little stigmatizing to say safety. And this is a really interesting thing that's taken root for us. It's a meeting that we hold with multidisciplinary team, including social work, public health, nursing, primary people who know the family, and both their case manager from Homeless Prenatal, which is a local family resource center. And we really sit down together and discuss if there is a family care plan, we review it and potentially update it. If there isn't, then this meeting could yield a family care plan, because we go through what are the strengths and resources that this family has or has been connected to, and what are the challenges that this family is facing, and are there still unmitigated risks that would trigger a mandated call to child welfare. And so what this does is it allows all of us to be together in a room. So if there are individual biases, hopefully they are neutralizing one another.
The steps is gather a first set of ideas, 12 to 15 total.
Sorry, Janet.
Read all ideas and get clarification as needed.
Thank you. So basically, what happens is you have this transparency, and we can call out how identities, power and privilege, social determinants of health all feed into this circumstance. And then we can have transparency in the decision, like when we decide to call or not call, why is it, so that people don't feel concerned that this was made for the wrong reasons. And it's really helped in our culture. Next slide, please. Oh, yes. And Marcy was going to speak to one other parallel in the larger macro system.
Yeah, so the collaborations that we formed are really at the heart of much of the Plan of Safe Care work that we do. Again, it's not about the document itself so much. Family Treatment Court, our Family Treatment Court is an integral partner, and the Family Treatment Court coordinator is part of our Plan of Safe Care leadership team. Family Treatment Court gets many referrals from Team Lily that Dr. Briscoe was talking about, and our perinatal stabilization team to intervene with a strong team-based approach as early in a child welfare case as possible, and collaborates with the Homeless Prenatal Program that Dr. Briscoe mentioned as a key family resource center partner for case management and family support. And also we partner with and depend on all the family resource centers located across San Francisco for case management and linkages to services, especially on the prevention side, as we do not have an official notification pathway. Team Lily also holds weekly case conferences to collaborate around their high-risk clients for planning and support. And a partnership with the Child Welfare Agency is really essential, of course. We have an FCS program manager on the leadership team and hold monthly meetings to discuss strengths and challenges in past cases and how to improve. And the emergency response leadership really makes themselves available to be contacted directly when there's a need for consultation or intervention on a case, which is really helpful. We're also in the process of forming a family-centered treatment collaborative to work with residential treatment programs and step-down partners to ensure needed supports are in place for parents in treatment, to not only place dyads together, but also keep them together.
Thanks, Marcy. And I see we're kind of out of time. So if you go to the next slide, some of the shortcomings we've learned, it's really been hard to do this as we were an unfunded grassroots kind of city and county organization of people who cared, but pulling this together with, bubble gum and shoestrings. So part of it is that our issues around communication, documentation, and a way to have a robust implementation are real. So anyone who's in our situation, we are happy to be contacted if you want to hear how we've done it so far. And we do have some lessons learned, but I think I want to make sure we leave time for the other presenters to share their work. So our slides are available and we're happy to be reached out to.
Hi, I'm Beth Van Horne. I am a public health researcher and practitioner at Baylor College of Medicine and Texas Children's Hospital, and I'm thrilled to cap off this awesome panel of Plans of Safe Care aficionados to share our adventures and our journey in the development of the Plan of Safe Care here in Houston. If you are a hospital, a community organization, go back, please. A hospital, a community organization, or other agency that believes the Plan of Safe Care would really benefit your community or your family, but you don't have quite the same level of state and government leadership guiding the development as some of our examples today, this example might be particularly relevant to you. Next slide. So we first learned about the Plan of Safe Care and the captive requirements during a needs assessment we were conducting in 2018. And this assessment was really intended to help us better understand the response to perinatal substance use in two big cities in Texas, Houston and San Antonio. And we picked those cities because they have very different landscapes in terms of substance use and the history of substance use by the community, as well as resources for substance use disorders. And the assessment, I'm going to stick on the slide for a minute just because we often refer back to this assessment to guide our work. So it was really a good foundation. So it included a policy review. I will tell you that it really wasn't a review. It was more just an enlightenment that many of our organizations did not have policies and procedures around responding to perinatal substance use. It included data analysis. So we were able to get death data from the Houston ME's office to really highlight the burden of overdose deaths due to specific substances. In Houston, this went a long way in helping us raise awareness about Houston's growing opioid overdose problem. Until we presented this data, most of the people that we interviewed did not think Houston had a problem. And so this really helped to elevate the awareness for that. We were also able to obtain statewide birth level data with diagnosis codes around substance use at delivery. So this helped us really highlight the difference between San Antonio and Houston, where San Antonio kind of leads the state in substance exposure and neonatal abstinence syndrome and opioid withdrawal. Houston's rates are lower than the state's average, actually, but didn't actually correspond with the overdose death data that we were receiving. So really kind of indicating that perhaps we're missing a lot of the prenatal substance exposure in our hospitals. And again, that data, presenting that data to hospitals was really beneficial in them saying, okay, maybe we need to do something and look at our data. We also conducted 100 interviews. I wish I was joking, but we did 100 interviews trying to really get the perspective of all the sectors engaging with pregnant and postpartum women who could have substance use issues, really from OB and pediatrics all the way to kind of law enforcement and the court systems. And then through those interviews and kind of a snowball approach, we established collaboratives both in Houston and San Antonio to bring together stakeholders, really to learn with us, to break down the silos that we were hearing about and physically observing, and then to help really determine next steps for their communities. And during these collaborative meetings, we had women with lived experience who came and shared their journeys, and we were able to do some journey mapping to really find out what helped and then where there were gaps and opportunities. And then all this information was presented to the collaboratives, and they collectively came up with 25 recommendations of how to support moms and infants impacted by substance use. And these recommendations were both just within a sector and then also cross-sector work. And then lastly, it's long, we took these recommendations and we sent out a readiness and implementation survey to our stakeholders to really figure out what were people in the community in the specific sectors, what were they ready to move forward with. Funnily enough, the plan of safe care development was actually rated really low on readiness. However, the power of collaboration, after the assessment, a group in Houston decided that they wanted to work on it. So they kept working on it. And this was spearheaded at the time by a specialty court. And many of the stakeholders that were in our collaborative participated. And so what we did was to get support, we applied and received a grant to be able to buy some of our time, to purchase materials, and to pay for some of the steering committee organizations' time and participation in a pilot. And this was really, really crucial because without that dedicated time and attention, we really, I would probably be listening here today instead of being able to present here today. Next slide. So in terms of the steering committee, we took that group of really enthusiastic providers that had started to work on it, and then we added a few other team members to ensure that we really had participation from all those sectors that would be involved. Because we really thought that in order for them to use it, for them to adopt it, we wanted to make sure it met their needs as well as the needs of the families that they were serving. So in the end, it included healthcare. We had OB and pediatrics. We had our biggest group was actually child welfare, both from the regional level as well as the state level. We had treatment organizations that had state funding to support pregnant and postpartum families with substance use disorders. We included the jail and their reentry program. We had a specialty court, and then we had our public health team. Next slide. So we used a Plan, Do, Study, Act framework to kind of guide that pilot work. So in total, we met 9 times. This happened to be started right before COVID, but we met 9 times over 21 months. To really kind of collectively identify the needs, to really review and develop our materials, and then talk about our pilot activities. So during our 4 PDSA cycles, we gathered a lot of feedback from our pilot sites, both from the moms that were participating and using the tool, as well as from the providers. And this feedback ranged from, like, the initial was, do you understand the words on this form and how to use it? To sort of, how is the plan of safe care helping you? What sort of things do you wish were included? What are you putting in your plan of safe care right now? And what tools do you need to support your use of this tool? Next slide. So in total, and honestly, thanks to extra time that COVID allowed us, one of the silver linings, we were not only able to create and pilot test the tool, but we were also able to create trainings and supportive materials to aid in widespread distribution. So this included 3 online self-paced trainings to familiarize organizations with the tool, a provider toolkit, and scripts. We have a script for a provider to introduce the plan of safe care to their client or patient. And then we also have one where the patient or family can introduce it to a new provider that they're working with. We also created video testimonials and exemplars. All of these are free and accessible through our learning platform. And these tools were really helpful in getting new organizations to feel more comfortable in adopting and implementing the plan of safe care. Next slide. We wrapped up the pilot and after listening to those interviews, and you can read some here, and the reactions that we were getting from those we were disseminating it to, we realized that this tool really could benefit many more families than just those with substance use. And we went and we had a lot of interest from our pilot organizations who are implementing to broaden this to support any sort of family who might need this help and support. Next slide. So we went back to our steering committee and we renamed our tool so that we could separate it from this just substance use world. So no longer plan of safe care, and it's now called the Family Care Portfolio. And we made some edits to this, to the forms, the resources, just to be much more inclusive of all family members, as well as those without a substance use history. Next slide. So this is how we kind of define our family care portfolio. It's really an organizational executive functioning tool to support families with kind of complex social needs and high medical needs, right? In our community, we have 34 birthing hospitals just in Houston alone and over 200 in the state. So we really, and no unifying medical records. So we needed a tool that could actually belong to the family, right? So this is given to the family and they use it as they see fit. And it really helps them demonstrate and communicate their strengths, their needs, and their accomplishments. Next slide. And just briefly, like we really expanded the use and really try to promote that this is really for just families who are experiencing any sort of chaos that's going on in their lives that kind of impacts their executive functioning, and those who kind of need more organization because they're visiting lots of providers. They may have multiple medical appointments. They may have, case managers, doctors, coaches, counselors, et cetera. And this helps kind of keep those people on the same page. Next. I'm not going to go through this, but our family care portfolio is actually a physical binder. So that's what that represents. And it has 7 tabs with various pieces in here. What I think is most important, so that family health and supports, that's similar to what I've heard our other folks talk about today, where it's really strength-based and it helps those providers really kind of understand what that family's story is so they don't have to tell it multiple times, and also recognize their strengths. And then the rest of these were tools that both the families and the providers saw were helpful to just help organize and keep things together for families. Next slide. And then finally, I feel like we could all spend hours talking about these successes and challenges. And I think I'll wrap up real quick so you can have some questions for Q&A. But challenges generally, like this tool is really individualized. It's very flexible, which is great for the family. We have found that it's actually kind of harder for some of our providers who are used to very strict fidelity, checklists, that is hard for them to grasp the flexibility of this tool. In terms of dissemination and adoption, we are not a state agency. We had the help of state agencies to build it, and we actually have the help of state agencies to disseminate it across the state, but we have not had we're working towards, I should say, being able to have agencies actually adopt it and, require their programs use it. But right now, we are kind of a 4-man shop going out across the state of Texas to disseminate and train folks on it, which is an issue in terms of ownership and accountability. Again, we're working towards this, but there is no kind of ownership and accountability, particularly around the counting piece. And then finally, we get asked this question all the time: how do you know it's working? And evaluating it. This is challenging when families are able to use it how they want to. And we're not the ones actually distributing it, right? It's being distributed through nurse-family partnership and parents as teachers and at hospitals. And so that has been a challenge, but we are continuing to work on that and have a usability study out now, and we'll have a randomized control trial soon. Next slide. I think we're going to open it up for questions. My email is here if you have questions or want to talk further about your work. Happy to do so.
All right. Thank you to all of our panelists so much. That was awesome. I wish we had more time. I'm going to immediately go into the questions that we've received so far. In the chat, we have a question. I believe this came in during Houston's presentation, but others can chime in. How does the plan of safe care document remain available to families, especially if it's updated frequently? Do they receive a written copy, receive updates through a system, or through verbal interfaces, or with whoever's managing their case?
So actually, for us, our plan of safe care family care portfolio is actually owned by the family. They're the ones who update it with their provider. So they're the ones who take it to their appointments. And so we have like our, a specialty clinic that's at our safety net hospital that's for perinatal addiction, prenatal care, and they use it routinely within their practice, right, to update it with moms, make sure it goes to delivery. That is different than it might be used in nurse family partnership, where they're using it with their coach and maybe using it with some other providers. So it kind of varies across, but we don't hold it. I don't know what's in anybody's.
Any other folks weighing in? How does it get updated with families?
We have had instances where we update the plan of care in a medical record in an area where that's not visible to anyone who would subpoena per se, or do like a my chart visible record, but that we can print it off if it's useful for the families, because sometimes it has all their contacts and who's working on what. But again, in our case, it's most often more about just revisiting this conversation and making sure that we're supporting them. So it's less about the document and more about the process in our case. But printing is scary, because then what if someone else finds it?
Yeah. Okay, I'm going to keep moving a little quickly through the questions so we can get to as many as possible. This one's similar. If the plan is created by hospital systems or child welfare systems, how is the plan then shared with the infant's primary care physician? Anyone can jump in.
In our case, we have the plan of safe care in a care coordination note that's visible across inpatient, outpatient settings and roles. Social work has access, nurses, doctors, and clinics that are not even necessarily in the same network that can see it through Care Everywhere. So it's in that format for the primary care, but it's ideal that if you can have a warm handoff about these families and actually just reach out to them directly, or to the PCPs.
All right.
I can add for Washington as well, caseworkers are obtaining a consent and making efforts to share the plan with all of the providers for the family.
Okay. All right. Next is how do you differ the pathway or support when parents are first introduced to a plan of safe care during prenatal care versus parents who are just learning about it, the plan of safe care and treatment options at delivery? So when, like, the differences in time frame when it gets first discussed.
I definitely would be a proponent of trying to have those conversations go down prenatally, as Emma was just asking. That's really when this tool is the most useful. I think when it happens in the birth hospitalization, it's not going to be as well formed or it's useful. You wouldn't have been able to do that preventative work. So I think in the hospital setting, its use is much more narrowed. So Emma's question about how to get it into the prenatal clinics is the biggest one, and hope that's one that we're kind of struggling with as well. And I bet you Washington or Houston has a better idea of how to get that in the prenatal clinics.
We are also grappling with that in Washington, trying to identify the best route of communication with our OBGYN partners and clinic partners.
We have actually partnered with one of our managed care organizations, and they are helping with their family resource coordinators to provide it to folks in OB offices. They're limited, but we actually don't even have to provide them anymore. We have given them the files, they print them, they create the binders, and they're handing them out. To answer the initial question, for us, it's really just about communication about how the tool is used. So when you get it prenatally, which is where we want you to have it, right? That's the biggest opportunity for you to prepare yourself to be a mom and to have all the things in place. That's what we talk about, right? This is preparation, and particularly if you think that think that child welfare is going to be involved at delivery, which in Texas, if you have an exposure, they are supposed to call no matter what. So you likely will have a child welfare person coming to see you, that this is really, really, really helpful for you to demonstrate everything that you're doing, right? And this is a tool to help you advocate for yourself. If you get it postnatally, we've had people in our foster care clinic who the child was 6 when they got it. And it really helps them just organize all the things that they're doing with their kiddos, right? And so to keep it all together, when they go to their pediatric appointments, they're able to take those things, show after visit summaries, so they can say, oh, okay, yes, they were prescribed XYZ, they were taken off at this date. So it really kind of just helps as a more organizational tool for them to be able to easily access their information.
All right, I'm going to move to our next question. For UCSF folks, when and how do the dyad meetings happen? During the birth hospitalization or on a weekly, monthly PRN basis? Are they in person, virtual?
Okay, so those meetings can be called by anyone on the team who's concerned. But a lot of the times, because we have a weekly case conference where we're talking about the most complex patients as they come down the pike marching towards the birth event, we don't call it until there has been a birth, but we are discussing kind of in a similar format on the way up. But then once there is a baby in the picture, because the context is changing all the while, hopefully, then we will call that the dyad care coordination timeout. And it tends to be a mix of in-person and virtual. Like there are some people in-house who will be in a room together and others who will Zoom in. And so it's really kind of called on an as needed basis as you know, a dyad comes into the hospital and we're thinking, what is the appropriate discharge plan for this family? And do we need to notify child welfare of this dyad, or can we support them in community and keep reassessing?
Okay, really quickly, I'm trying to get to as many as possible. How do you continue building upon the plan after transitioning home from the birth hospital to ensure it doesn't get lost? And as well, how do you co-develop with the family? I know that's kind of 2 different questions. And I know we've kind of touched on the ways it's co-developed with the family. If anyone has tips for like how to make sure it doesn't get lost.
Bonnie, I think you touched on something that's really hard, and I don't know if I'm jumping in because of silence, but you know, how often people are reviewing the plan of safe care, who's kind of overseeing, if anything, it's patient-centered, but like who's checking in with them? I almost think of it as like a learning plan for one of our medical students or trainees where like, how's it going? Are you achieving your goals? Do you need more support? But I think in our model, we tried to have the patient identify like their number 1 person and have that person kind of help them co-own this. But I think it's different in every system and hasn't been really well fleshed out.
And I would just say that often sure they're connected with a public health nurse and also the family treatment court team. There's a lot of support. Again, like I said, we're trying to partner with the residential treatment programs and others so that there's really a team surrounding these families after they leave the hospital. That's really key, and that's something we're continuing to develop.
Right. All right, I'm going to bring it to a close. We have 1 minute left. If we can just pull up, I know we may not have time, but you will receive a link to our evaluation survey that will be emailed to all attendees. It's also in the chat. Our panelists are putting their emails in the chat if you would like to contact them further. The recording for this webinar will be up on the Maternal Health Learning and Innovation Center website at maternalhealthlearning.org. And so we'll be sharing the recording and slides. That that is mostly everything we have. I think, again, we just want to give a big thank you to all of the panelists for sharing all of your wisdom, your lessons learned. This was really, really helpful. And we just thank you again so much for all of your work. All right. With that said, I want to thank everyone who attended today. Again, if you have additional questions, reach out at maternalhealthlearning.org, and we hope you all have a great rest of your day. Thank you so much.